For this to truly be a national vaccination effort, we must ensure equal access to the vaccine. National, state, tribal, local, and territorial practitioners and health workers from across the country working together can maximize access for all populations, especially those who are more likely to be exposed to or develop serious illnesses from COVID-19 and those who may face barriers to vaccination.
Me dolió un poquito, pero todo bien.
We have to be apart from one another is really hard.
It's all a part of Let's Do This, a campaign to educate and encourage.
There are more COVID-19 cases, hospitalizations, and deaths in areas where racial and ethnic minority groups live, learn, work, play, and worship. A comprehensive vaccine program provides equal access for all populations across the nation.
Welcome to this town hall meeting as we engage in some critical dialogue in the midst of this health pandemic. I want to first start by opening up a poll question for our viewers to join in. And the question is, who's in the audience today? What type of organizations do you represent? I would ask the moderator to put the poll on the screen so we can know who's participating with us today. Moderator? Okay, if we don't get the poll up, I guess we want to move forward and come back to the poll after that, if that's okay. First of all, I'm Derek Johnson, President and CEO of the NAACP, and it's an honor for me to moderate this panel discussion. I'm going to do all I can to summons my Oprah Winfrey so that we can move this journey along. And if it gets too boring, that means Oprah's not talking to me at that moment. Oh, there is the polling question. Oh, I didn't see it. There it is. So who's in the audience today? We have 18% of you are from public health, 12% of you are healthcare system provider or administrator, 17% non-governmental health and public health organizations, 3% pharmacy, 10% medical or public health academic institution, 12% from community-based health organizations, 15% from government, faith-based organizations 4%, and private sector 4%. So now that we have a temperature of who's in the audience today, I'm going to start this session off with a question to Deborah Fraser-Howes. As founder of Choose Healthy Life, you have brought to the forefront the importance of engaging community leaders and institutions, particularly Black faith leaders and churches, as champions for vaccination and to serve as sites for vaccinating communities where they live, work, and pray. What have you learned doing that work that you would like to share with this audience about how they can engage in their own community to ensure the populations most disproportionately impacted by COVID-19 have access to vaccinations? Ms. Howes. I think you're on mute there.
It's Zoom. It's with the world these days. Thank you, Derek, and thank you very much, and thank you for the question. I learned a lot between being the founder of the National Black Leadership Commission on AIDS and now the founder of Choose Healthy Life, which was created to address both COVID and health disparities in general. What I've learned basically is that when the community is in crisis, no one man, woman, organization, health department, no one entity can save the community. What you need to do is bring everyone together and develop a Marshall Plan and make sure that the community itself is at the table and making decisions about how one one proceeds in doing this. I know that they wanted me to talk a little about Choose Healthy Life. So just let me tell you that Choose Healthy Life was created out of the model of the National Black Leadership Commission on AIDS, where we brought together leaders from around the country. You know that one of the leaders that I had on Blacker was Hazel Dukes. You brought together leaders who had these wide constituencies and knew what they were doing and could make decisions and help in the community. And one of those groups of leaders was the Black clergy. At one point, we had 17 affiliates around the country, all headed by Black clergy. So when this pandemic hit and we saw the number of deaths happening, we called out to the Black clergy, same Black clergy, some of it had been involved in AIDS, and asked them to come together to help develop the plan that was going to be necessary for them to reach out to not just their congregations, because the Black church is no longer someplace that you go on Sunday. The Black church is every day. The Black church is feeding the hungry, clothing the naked, and doing all kinds of other programs. One of the things that was very clear from the very beginning was that the church needs to be resourced. We should stop sort of throwing things at the church and not giving them any resources to stand themselves up. So we went to Quest and got a grant, several millions of dollars, and we funded 50 Black churches in 5 cities. And the cities are New York, Newark, Detroit, Atlanta, and Washington, D.C., 10 churches in each city, so they could begin. We really started as a testing program, so they could begin testing. We had to, go into the community, understand where the testing desert were, develop heat maps, really data-driven programs. So it's not okay to do things that are cute anymore. We don't want people taking, photos and photo ops and just speaking to the community. People have to get their hands dirty. They have to roll up their sleeves and actually do the work. And we were lucky in that we found those clergy people who did do the work. So we've got clergy in these 5 cities, and their focus is testing, education, now vaccine distribution, and building the infrastructure of the churches, which was important. Each of the 50 churches now has a full-time public health, Black Church Public Health Navigators, what we call them. We also funded the local United Ways to give support, professional support, to the 10 churches in each of their cities. And we've developed an infrastructure that is allowing us to now expand to do vaccines. We are going to be announcing tomorrow in New York that under the Choose Healthy Life banner, chaired by both Reverend Al Sharpton and Reverend Calvin Butts, we're expanding to include churches in the city that will now become official vaccination sites along with the New York City Department of Health and the Office of the Mayor. So there is also an advocacy piece that's necessary for the clergy. And they've been doing advocacy longer than anybody else I know, and they do it well. And when you can't get to the vaccines and you get to the clergy and you pull them together, they pick up the phone and call the mayor and the governor, all of which who come into the church when they want to be elected, and let them know how important it is to have the vaccines, where the vaccines need to go, and that they need it now. And we've got that, and we've done it, and we're doing it very effectively. Reverend Raphael Warnock is the chair of what we're doing in Atlanta. And as senator now of Georgia, we're focusing on doing advocacy on a national level. And first and foremost, and I think the most important thing to end the answer to this question is that you got to respect the people that you're servicing, or don't service them. If you don't respect them, if you don't respect what they think and they feel should happen to them, then leave them alone and let somebody else service them. You have to build their resource base. You have to build their capacity to deliver whatever services that they're being asked to deliver. And as far as the services are concerned, you have to bring the services to where they are. And I think that that's the answer to that question.
Great. Thank you, Ms. Fraser House. You got to respect the people if you're going to work with the people. I love that. Ron Herrera, thank you for all the work that you're doing. Let me go into the question for you. The phrase essential worker wasn't even in most people's vocabulary a year and a half ago. As the president of the Los Angeles County Freedom of Labor, AFL-CIO, you have a unique perspective on the workers that keep America's grocery stores stocked, build our homes and offices, educate our children, and get people and goods to and from where they need to go. What are some of the things that public health and healthcare organizations should be focused on to ensure that essential workers are not left behind as more COVID-19 vaccines become available? Ron. Ron, I think you're on mute.
Thank you.
There we go.
Workers are at the center of every part of our society, as work is seen as more than just a job, but an expression of our values, whether that be working in public service or the fundamental drive to provide for a family. Our jobs are more than just a way to make money. Frontline workers are critical to keeping our economy going and getting us through the pandemic. Many picture medical staff when thinking of frontline workers, but the truth is that's only one part of the story. We have restaurant workers, janitors, sanitation workers, and even delivery drivers, just to name a few. These workers are just as likely to be exposed to COVID-19 as medical staff due to the nature of their jobs. By prioritizing our frontline workers, we are prioritizing Black and Brown communities who are more vulnerable to infection. We can break the cycle of which COVID-19 is spread from the workplace to the home, then into our communities. It's an insult to these brave workers to be labeled essential and then have their employers treat them as though they are disposable. There are a few things to consider in terms of access to the vaccine. While common knowledge, it is worth stating that workers do not live at work. They go home to their families and their communities. So we must consider those frontline workers, the ones we are leaning on the most, and their social demographics. We know all too well that workers of color are more likely to hold positions on the front lines that cannot be done remotely. They are also less likely to have access to PPE and paid sick days, forcing many to make the impossible choice of having to go to work with symptoms and putting food on the table. These workers are more likely to be multi-generational housing, and with the massive job losses due to the pandemic, many are now primarily breadwinners of the family. It's an impossible position to be in. It is also important to consider that the vaccine implementation strategy must prioritize people not only based on their age, but also their occupation. We must protect workers at their workplaces, whether it is at a school, a warehouse, or a factory. Demographically, essential workers of color are younger when compared to the overall US population. So if vaccination distribution is only based on age, a whole group of frontline workers who are at greater risk of contracting the virus and spreading it would be excluded from having priority access to the vaccine. In the end, the vaccine distribution will take time, and that is something workers in communities of color don't have. There are things that our leadership can do now that can help save lives. We can require PPE in all workplaces. We can increase enforcement of public health orders to ensure workers and customers are safe, such as in Los Angeles and Mayor Garcetti's executive orders. We can promote and enact progressive policies that could keep workers safe, such as public health councils passed in Los Angeles County, allowing workers to make workplace recommendations in the name of public health and protecting them from retaliation when they speak up. Labor unions are crucial and trusted institutions that has already partnered with government agencies, health organizations, and community groups to help decrease the spread of COVID-19. We have built relationships of trust with our members and their communities, who are vital in helping to educate the general population on the importance of getting vaccinated and dispelling any misinformation. There's no doubt in my mind that we can create and ensure an inclusive and comprehensive COVID-19 vaccination campaign that is centered around workers and our vulnerable communities. If we don't control the spread in the workplaces, we won't be able to decrease the spread in our communities. By working together, we can empower workers to protect themselves. We also helping to protect our communities and our greater society. Thank you.
Thank you, Ron. Center the response around our critical workers, because it will be through our critical workers that we can protect all of our communities. So we're going to move quickly to Jill. Dr. Jill. Navajo Nation was among the hardest hit by COVID early in the pandemic and faces many unique challenges in vaccination implementation. Despite these challenges, you've seen some big successes over the past months. What lessons can you share about increasing community acceptance? What strategies have you tried for getting people to vaccine or getting vaccine to people? And how have they worked? Dr. Jill.
Thank you, Derek, for those questions. We received our first vaccine shipment back in mid-December. We received Pfizer back then. Today, we have about over 100,000 individuals on the Navajo Nation vaccinated, and we appreciate all of the support from the Biden administration in allocating more vaccines to tribal communities. And things may not turn out as you expect sometimes, as we would think that the vaccine hesitancy has been brought up numerous times, and in the Navajo communities was really just critical to provide a lot of community education on who, when, and where vaccines are going to be offered as supporting community acceptance. So just basically being transparent about the number of vaccines being received and allocated. And through our partnerships with health facilities, I think that's one way. On the Navajo Nation, we are structured where healthcare facilities most often is the ideal location to receive vaccines. So just understanding and working with our healthcare system and working with our tribal leaders, and also building a platform on social media, and also town halls are very critical. So those are some strategies that I just mentioned were the town halls. We did have the Pfizer CEO come on board and attend a town hall as well. And even early on, as we also participated in the Pfizer study participation through Johns Hopkins University. And so there was some preliminary education and also knowledge about the vaccine being available to the Navajo people early on before it became generally available. So just the existence of some of these, I think, set up a perfect scenario to support community acceptance. But in regards to getting vaccine to people, and that is what I mentioned, encouraging our weekly attendees on the town halls, and also a lot of radio campaigns, and also we try to do weekly updates of where these mass events are, and explaining to the individuals and having that available on a weekly basis was very important. But also public health messaging is also a good takeaway point of this, and building our own messaging with our entire healthcare system and structure. But the advice I would give to organizations on how best to meet Navajos or other American Indians population in your communities around acceptance is just collaborate with local entities to determine what culturally appropriate strategies work, and also ensuring that vaccine prioritization is supported by tribal leaders and community members. As we all have different prioritization, we do follow the ACIP guidelines, but we also address our own tribal needs and sovereignties to identify how our population is best served. As we know, in the Navajo population, we do have a high-risk population. So we tend to also try to support other types of population compared to what the general guidelines are in some cases. So thank you very much, Derek. Back to you.
Wow, really amazing work and important work. And it kind of goes back to what Dr. Fraser House said earlier. You have to respect the people to help the people. And the work that you just described is showing the tremendous respect you have for the Navajo tribe. So thank you for sharing. Now we're going to go to Ingrid Johansson. Your organization has been established in the community for nearly 15 years. It works with local FBOs and health departments to give seasonal flu vaccinations to vulnerable immigrants and minority populations. Can you tell us a little bit about how your organizations have pivoted to include COVID-19 vaccinations in your mission, and what has been learned so far about optimizing equitable access? How can an organization like yours serve as convening partner to bring others to the table to increase reach in the community? Ingrid Johansson.
Thank you, Mr. Johnson. Good afternoon, everyone. Thank you to the CDC and the Biden-Harris administration for this invitation to share with you our model for reaching hard-to-reach communities with mobile vaccination. And I think I'll just first give you some background about the collaborative, and then share how we've transitioned just recently to be able to provide COVID vaccine for our existing partners. So the MINI program, it stands for the Minnesota Immunization Networking Initiative, was started 15 years ago. We just wrapped up our 14th season of vaccination. And we're a community collaborative aimed at reducing barriers to seasonal influenza vaccinations for underserved populations. So just like with COVID vaccine and COVID disease, persistent racial disparities exist with influenza vaccination for BIPOC communities. And at the same time, communities facing health disparities also experience a greater burden from serious influenza complications. So our model brings free vaccines into community settings thanks to multiple trusted partner organizations that are really deeply connected to community. And it's led by our health system, mHealth Fairview, but made up of multiple community partner organizations. And on our leadership team, we have representatives from the African American community, Vietnamese American, Karen American, Hmong American, Liberian American, Native American, and multiple Latinx American organizations. And our model really aims to reduce barriers that contribute to vaccine inequity. So we make it free, we make it convenient, and we vaccinate in trusted spaces. And because we do it this way, we're able to serve the whole family from baby to grandma all at one time. We are nurse-led, so these are all nurse-driven. Each clinic has a lead nurse, and our partners are the hosts, so they engage in the outreach and also help us staff the events. We always make sure materials are available in the client's preferred language, and we always have interpreters present. And we vaccinate in community settings. So as I mentioned, that means a lot of different places. It means faith communities, many, many churches, mosques, temples. We even vaccinate in libraries, shelters, city park pavilions, parking lots, marketplaces, Hmong markets, Latinx markets, mobile home communities. And this year we even vaccinated inside an ice fishing shelter for the first time. But faith communities, I would say, are really our largest partner and serve as that truly credible, trusted space for the many diverse communities we serve. And the majority of our clinics are held in zip codes that have a high burden of health disparities. So we're also really intentional about making sure we're getting into the communities that need us the most. We typically vaccinate just under 7,000 people every season in that kind of tight, influenza vaccination season of about 3 months. And we hold over 125 clinics. We're really no frills, low tech. We have good data, but we keep it simple, and that's really enabled us to be quite nimble and responsive. We vaccinate on weekends, evenings, weekdays, because typical 8 a.m. to 4 p.m. hours really don't work for a lot of communities to access healthcare. So we do a lot of evenings and weekends. And our team of nurses are really amazing and diverse and love community and really represent many of the communities that we serve. So, because vaccine equity has always been our mission and mobile vaccination is really our skill set as a collaborative, we started planning early, knowing that, a COVID vaccine would eventually come. It would eventually become a reality. And we took a lot of the learnings from last fall, vaccinating in the middle of a pandemic. We implemented social distancing and PPE, and we held events outside, and we did a lot of COVID education while vaccinating for influenza. We took those lessons and so that we could really intentionally plan for transitioning to COVID vaccination. And we actually surveyed our partners last fall after completing their annual flu vaccine clinic. And we asked them, would you be interested in hosting a COVID vaccination clinic in the future if we were able to provide that vaccine? And many of the partners said yes. Pretty much all of them said yes. And this rang true as the vaccine started shipping. Our partners were calling and they were asking, when can we work together? When can we bring this to community and to our people? So, we already had a strong foundation and plan and network. So when we were first told from our incident command center at the health system that we would be able to receive an allocation of vaccine to bring to community, we had already had several conversations with our partners. And one of our oldest partners, St. Mary's Health Clinics, was just ready to leap. And it was about a 3-day period from learning we'd get the vaccine to holding the clinic. St. Mary's Health Clinics serve uninsured, predominantly Latinx community members with free medical care, but they don't have a mechanism to receive their own vaccine. But they have incredible resources to community and Latinx churches and the Mexican consulate and multiple other nonprofits serving Spanish-speaking communities. And, a lot of these groups already had rosters of folks 65 and older that might have been receiving services from programming through the CARES Act. So they already had an incredible, database with which to launch outreach. We staffed the clinic as we usually do with majority Spanish-speaking staff for this community. We had, including one of our team members who's a physician originally from Mexico, who was able to answer questions, assist with screening. And, many of the folks in this population are undocumented and ineligible for insurance, but it's so important that we provide services in a way that makes people feel safe and really, really emphasize this is free and safe. This was a really successful pilot. We have now done 3 events with that community partner and have more on the books, have multiple events running now, including 5 clinics with our African-American churches. We have scheduled our clinics with some of our Vietnamese Catholic community church partners, Nigerian and African immigrant community partners. And we're working with our Hmong, Karen, and Somali American partners right now to set dates as we speak. So we've learned that this is more labor intensive than flu, takes more resources, but because we had this really solid foundations with our partners and credibility as community vaccinators, we were able to react quickly and urgently because we're not building this from scratch. So I just can't stress enough how important it is to have relationships before a crisis hits and know that, we're all building relationships for the future and what the future may hold for us to work together.
Wow, thank you, Ingrid. It shows that if you understand the landscape of communities, you can tap into existing networks to have maximum impact. And what you just described is maximize impact by tapping into networks. We're going to move now to Susan West Levine. And with this question, community health centers like yours serve a vital role in the community, especially a community as diverse as Lowell. How has your work enabled you to build the foundations for strong community outreach activities to optimize equitable access to COVID vaccine? How have you worked with local community partners and public health departments to strengthen COVID vaccine access for all? And what strategies can you share for building such partnerships? Susan.
Great, thank you. Thank you, Derek. It's really a pleasure to be on this panel with all of you today, so thank you very much. Lowell is indeed a diverse and vibrant community. We are home to many refugees and immigrants coming from across the globe. We serve roughly 50,000 people each year, which is about half the population of Lowell. And nearly 40% are best served in a language other than English. Just want to give you a little bit of context. Over 25 years ago, Lowell became home to a growing number of Southeast Asians, mostly Cambodians, who had survived the Khmer Rouge genocide. Despite complex physical and behavioral health needs, this community was not seeking health care. We learned that our Western approach to medicine was scary to people who feared government and saw medical equipment that looked eerily similar to weapons of torture. Our health center didn't look like the places of healing from their home country. So together with our new community members, we created the Meta Health Center. Meta was the result of countless community meetings, focus sessions, and modeling to fully and truly understand their needs. Meta in Buddhist Sanskrit represents the words love, kindness, and compassion. For our Buddhist community, the word Meta instills a sense of trust and belonging. Meta has become the model for our entire health center. This is to say, our work in building trust with our patients and creating partnerships to facilitate that trust started long before this pandemic. Along with the nearly 1,400 community health centers across our nation, we have been singularly focused on building trust and building community since our very inception 5 decades ago. And for some of us, 6 decades ago or more. We do that by continually looking to our community to guide us and to inform our work. That community includes, for us at the health center, our board of directors is majority patient-led. Our Meta Health Center is just one of many examples of the power of that community building. It's something that countless other community-based organizations work on every day as well. And it's how we all know that keeping vaccine education and administration local and personal is essential for the people we serve. I'd like to share with you, just about 2 weeks ago, we began vaccinating seniors 75 years of age and older. In Massachusetts, we're in phase 2, group B, but this was back in group A. And among our first 250 patients receiving the vaccine, 46% were Southeast Asian, even though they only comprise 39% of our total patient population in that age range. This early data means that our years and more recent targeted efforts to reach our Southeast Asian community, who are among those disproportionately impacted by this pandemic, are working. But it certainly doesn't come easy, as some of my panelists have shared. We spent countless hours calling, recalling, and following up on seniors who were eligible to get the vaccine. Our multilingual patient service center grew from 11 employees to 24, and our community health workers visited neighborhoods and gathering places to answer questions, provide information, and mostly to provide reassurance about the COVID vaccine. This reach is also made possible thanks to our mission-aligned community partners that lean on one another for support, service, and learning. Partners include community-based ethnic, religious, health, and social service organizations, but as well, key community leaders and influencers. We share the same purpose and focus on our local community, our local challenges, and our local dreams. Little could we have imagined how essential those relationships would become throughout this past year. As we entered the vaccine phase of this pandemic, we convened our coalition of community partners to collaborate on developing and implementing a robust education campaign that feels local and, again, feels personal and is culturally and linguistically tailored. We created, as you can imagine, we created print material and public service announcements, social media appeals. We participated in programs on local ethnic cable TV as well. We hosted community and faith leader forums and enlisted our influencers to create videos telling people #ThisIsMyWhy. We all serve as ambassadors to reach, engage, and inform, to boost vaccine confidence and assure equitable access. But building and sustaining partnerships requires continual nurturing. And that must be guided and led by community members, as you've heard with our panelists today. A network of local organizations is at the core of any public health response. If your organization is part of such a network, turn to it for your local strategy. If not, find the natural partners that exist and let them guide you. Partners require resources too. And I was so glad that Deborah mentioned this as well. You know, we have to remember that much of this work and many of these partnerships are unfunded. If you are a funding agency, and Derek, I wasn't sure on our list if we saw any funders there, but if you are a funding agency, consider directing resources to support the work of these partnerships and these community-based organizations. Our coalition here in Lowell, with support from the Greater Lowell Community Foundation, we made the decision to offer mini grants to our community partners so that they could assist in community vaccine education. Stipends are another great tool to support the work of these community-based organizations. I can't underscore enough, we ask a lot of our community-based organizations, many of which are smaller, and we need to find ways to support their work because they are closest to understanding the needs of our community. And yet, in the end, it's all about racial justice. And we all know that COVID-19, this pandemic, is just yet another lethal reminder of the persistence of systemic racism. Through all of us participating in this forum, we can turn advocacy into action and permanently change the systems and normalize equity so that the next crisis does not wreak the toll that this one has. Thankfully, we are now in the hope stage of the pandemic, and our collective duty is to make sure that that hope is equitable and enduring. So thank you so much, Derek, for the question.
Yeah, thank you, Susan. And I like the point, building and sustaining requires maintenance, and I'm going to add resources. All right. So now we have about the transition. I'm going to ask the audience to do another survey, and I'm going to ask the poll. I'm going to ask the moderator to put the queue up. What strategies will you use in the future to reach communities at increased risk and ensure they have equitable access to vaccines? So I'm going to ask you for all of our audience to populate your answers after hearing these amazing presenters. I'm doing the best I can as I channel my Oprah, here. All right, we have any responses yet? What do we got here? Let me see. Engage community leaders, 23%. Partner with community institutions, 19%. Adapted existing infrastructure, 7% tailor communications materials and channels to be responsive to the needs of communities. That's really important. 31% invite members of the community to participate in outreach. That's absolutely vital. So as we begin to transition to the next phase of this conversation, put my screen so I can see everyone. Want to kind of have somewhat of a dialogue here. I'm going to ask our panelists questions, and anyone can jump in at any point, unless you ask me to direct the question to anyone. I want to start here. How has your organization served as a convening partner to bring others to the table and increase reach in community, while also addressing equitable vaccine access? Who would like to take that question?
I'm happy to take it.
All right.
Okay. Since a lot of what I talked about were those community partnerships, I thought it'd be helpful to tell you how those came about. In Lowell, we have an organization called the Greater Lowell Health Alliance. It's a local nonprofit that was founded about 15 years ago by our community hospital, Lowell General Hospital. The mission of the Health Alliance is to build and to sustain an alliance of community-based organizations. So we've been fortunate that we have a natural alliance that has been in existence for quite some time. The Greater Lowell Health Alliance performs our community health needs assessment, and that needs assessment is done every 3 years. And then they develop the follow-on community health improvement plan, and they host committees from across the city, actually across Greater Lowell, all the surrounding towns, task forces to work on our community health improvement plan. So we had that foundation that existed, that pre-existed with these community partners. So for us, and I'm actually chair of that board, so that was pretty fortunate for me this year. So with a phone call, we were able to quickly convene more than 30 partners through this alliance and seek their input and assistance in developing our local COVID vaccine campaign. These partners include some of the ones that we've mentioned before, but in addition, like our city health department, our university, our community college. And I do want to mention a couple of our ethnic community-based organizations, mostly to give them a shout out. Our Latinx Empowerment Center, the Massachusetts Association of Portuguese Speakers, and our Cambodian Mutual Assistance Association, and of course, faith leaders. So we have this nice amalgamation of fabulous community partners that convened, and we meet weekly. And so we are as about as real time as we can get in sharing information to improve our efforts here. So they're not only assisting us with our community education efforts, they're advising us on the perceptions, the challenges, as well as additional needs in the community. And it's been, we could not do this work without them. At one point, just as an example, when we were in phase 2, when we were vaccinating our seniors, 75 years and older, we noticed that we had some available, shockingly, we had some available vaccine appointments. And so we already had this network of 30 organizations. So we quickly put out an appeal and said, look, we've got appointments. So, you know, find your community member, the community members that you serve, and let them know. Because the community members that they serve are, by definition, at higher risk of COVID. And so we've reserved slots in our health center appointment schedule for community partner members who, regardless of whether they're patients of ours. And that is just one way where we're trying to leverage the community partners and provide access to this vaccine through them. So thank you, Derek.
Well, good stuff. Next question, anyone can take it. What are some of the challenges in reaching essential worker populations? Sound like this is tailored for you, Ron. What are some of the challenges in reaching essential worker populations, and how can communities ensure vaccination access for essential workers to is prioritized?
I think, you know, we have to understand that there's a lot of different industries in labor. You know, there's a lot of different classifications, a lot of different work sites. And like I said earlier, We go from janitors in office buildings to sanitation workers, to school teachers. You know, the interesting thing when you talk about education, you don't think that it's a workplace, but you have multiple staff doing multiple things in a school. And it's very, very important to identify, you know, the populations of these different sites. How do we ensure vaccination to these folks? We have to make it available, sometimes the hard way. And we have to be critical of our legislators at times. We have been. We are definitely, you know, we're 300 affiliates at the county federation, and we stand together to get, you know, workers vaccinated. We have the same message in that contain the virus in the workplace, especially in communities of color where you have multi-generational families living in an apartment or one home. How do you stop the spread when, you know, a worker of, let's say a minimum wage worker probably doesn't have a car and he has to get on a bus to get to work? If the regulations aren't up to standard within that workplace, that worker's going to have problems. He's going to get on that bus, go back home, and then go to, you know, tiers of different, his sons, his mom, his dad, right? And then, you know, they need, you know, a family needs subsistence, so he's going to have to go to a store. He's going to be in the community. So we are definitely outspoken in this matter, because not all workers are in the middle class. And those workers most vulnerable are the ones that make less. And, you know, as a labor movement, you know, we look at the labor movement is with our nonprofit partners, with our community partners, with clergy. It's just not, you know, labor unions. We're broad in our thinking because it's going to take a community of workers to access this vaccine through pressure at times.
I'd like to add, Derek, I'd like to add something to what Ron is saying in regard to essential workers. I think that it's critical, and I know the Biden administration and CDC will, moving forward, to determine, you know, the broad range of essential worker. There's not sort of a standard in the United States now about who an essential worker is. In some states, clergy are not considered essential workers, yet they've been at the burial sites of people with COVID. I'm sure they've been exposed to family members with COVID. They've been counseling people. People are having some very serious mental health issues right now because of isolation and the distancing. And in some states, they just weren't considered essential workers. And when we started to ask, how are we going to get the clergy vaccinated? We got pushback in some cities that they were not accepted. They absolutely are. So we have to come to some agreement with that, and we have to prioritize correctly. You know, the community talks a lot about the Tuskegee experiment, but you know what we send out, the message that we send out, is you don't have to look that far back. I mean, you remember when we had the anthrax scare on the Hill, and we were rushing to get the predominantly white Senate staffers, Cipro, a drug that would help protect them from anthrax. But yet the workers in the postal office who died, you know, as a result of anthrax, they weren't prioritized. So we're going to have to, we really need to take a minute and look at who is the essential worker. The janitors and the people in the cafeterias and the clergy. We really need to take a better look at that.
How do we define what's essential? Oftentimes it's based on relationship. And invisible people are not defined essential, but if they didn't do the work, we will all feel the essential nature of the work they were doing. So that's a great point. I'm going to direct this one to you, Dr. Jill Jim. Building trust requires awareness, and sensitivity to community concerns. What are some of the strategies to stay connected to the communities we serve and sustain trusting relationships? Dr. Jill Jim.
Thank you, Derek, for that question. I think, like I mentioned before, there is just a lot of community information that we have to give out to the community, especially about prioritization. Where are we at in prioritization? Also letting them know to also calm down as we are not getting enough vaccines. So there was a time period where we did have a lot of individuals wanting to get vaccinated, and there was all the safety messages that we wanted to provide to them. There was obviously a lot of the concerns, even with the 2 vaccines, and now we have a 3rd vaccine. So people are interested in receiving information, and at the same time, we need timely information to get these vaccines out and making sure people feel safe. And I think a lot of that just meant like we were able to get leaders and also healthcare workers and providers vaccinated first to say this is okay. So those were a lot of the strategies that we used. And when there were also some healthcare providers that didn't get vaccinated, but I think changed their mind, but offering like the role playing of receiving a vaccine, I think making that available, but also answering a lot of questions. We had several town halls where we had our partners on the call to answer questions from the community members to ask about vaccines. So I think just making that time available for the FAQs, and we have some on our webpage, and answering those hard questions. Some information we couldn't have available as we were still trying to understand vaccines in general. But I think just staying connected and finding some sort of way to answer questions and respond, I think would be my message to maintaining trust and to your community members and also partners and organizations within. So back to you, Derek.
Thank you. That was very helpful. And Ingrid, one thing that jumped off the page for me when you were talking, the many different type of communities you're working with. You have to cut across cultural differences, language barriers. What lessons can you share about best strategies for increasing community vaccine confidence, knowing that different communities have different histories with the vaccine or medical profession? What are some of the strategies you would recommend?
Yeah, that's a really good question. You're right. We have such a wide range of communities that we serve, and it's not the same approach for everyone. And I think going back to the question that you also just asked about building trust is a really big part of it. And being aware and sensitive to the community concerns. So we've really, committed to this motto of, to build trust, we need to show up and stay. And when we launch a new clinic with a community partner, we have every intention that we'll return if we're invited back, because these relationships aren't maintained if you just drop in and drop out. And I think one of the earlier speakers this morning said that public health really needs to be physically present. And I think that really describes our work. I mean, we spend so much more time out in the community than we do behind a desk. And we've even followed community leaders as they've moved from one organization to another, because they've been that trusted messenger, and we have had such history with them that we stay engaged, even if someone's had a job change, for example, when they're really that trusted messenger for the community. We have to follow through and maintain good communication. And for some of our cultural communities that we're working with, like our, email is not always the best way to communicate. Some partners prefer different ways of communicating. It might be, really important that we have a face-to-face meeting or phone call. We listen and ask questions in a respectful manner. So, for example, if we're vaccinating in a mosque, we ask ahead of time, do you need us to bring male and female vaccinators and vaccinate in different areas? We make accommodations for privacy. We share food. We recognize concerns around legal status and make sure people know that their information is protected. We work in their language whenever possible. And we show gratitude for these partnerships. So I think all of that has helped us have a foundation of trust. And again, it's really the trusted messengers that are essential. And that message has been really, I think, shared well in this conference. The partners have the credibility, and what our team does is help make it accessible. So it's not forced, but it's offered so people have a real choice. Our nurses love talking with people, answering questions, sharing personal stories of why they chose to get vaccinated. And I think one strategy that's helped us increase community vaccine confidence is working with nursing groups. So, for example, like the Liberian Nurses Association of Minnesota, the Nigerian Nurses Association, other healthcare organizations like the Hmong Healthcare Professionals Coalition. You know, these are groups that are filled with interprofessional health providers of the community and are so well placed to be able to be that trusted messenger and our partner. So they give us that credibility when we come in with them to help provide this vaccine. I just heard a fun kind of anecdote this last weekend. One of our community partners who is a nurse leader, she's in nursing leadership through our hospital system, and she's Nigerian American. And she said that her elderly mother-in-law was absolutely terrified of the COVID vaccine and was very hesitant, but watched her receive her vaccine and observed her for about a week to see what happened. And obviously observed that she remained healthy and lively, so decided herself to receive it. And now we're holding a clinic right at their church for others in that community. So just, building trust takes a long time and is intentional. And but through that, you're able to increase confidence. And I feel like we're going to see more hesitancy later almost than we are now, because now there's not enough vaccine. And so I feel like what we're feeling right now is urgency. But I think that this hesitancy piece and confidence piece is going to persist with us for a while as vaccine becomes more available.
I was talking and on mute there. Anyone else? How do we maintain confidence? Because many of us come from communities or serve communities that have not always had the best historical experience. Anyone else want to lean into that? Building and maintaining confidence in this moment of need.
I'll talk to it for a minute, Derek. Thank you. I think that there are two things. One is listening to the community. When you see an obstacle and you're having a problem getting something through to the community or understanding what's going on, you should ask them why is there hesitance? Why? And then acknowledge that whatever they tell you is a fact. And then when you accept it and acknowledge it, move forward. A friend, I'm sure both of ours, Jesse Jackson, once told me a long time ago, Deborah, keep your ear close to the community. At least the community begin to see the generals as the enemy. That would be a problem. So you keep your ear close to the community, and you have to have a sort of kind of graceful sensitivity when you're dealing with the community. We had an event at Canaan Baptist Church, and there was a senior citizen there, and she. We struggle with this registration process for testing, and the vaccination process, registration process is also difficult for some folks. And she was sitting there looking a little bewildered. And I said, "Ma'am, can I help you?" And she said, "Yes, baby. I've been helped." And I said, "Are you okay?" And she said, "Yes." And she said, "You know what they did? They gave me an email." And I said, "Yes, ma'am. That's how you're going to get your test results back." And she said, "Is it mine?" And I had to stop for a minute and say, wow, she didn't have an email address. So we all supposed that, but I had to listen to that. And then I understood that her friend Sally next door they probably still using house phones. They don't have a lot of cell phones. She only takes her cell phone out when she's going into the street in case something happens to her. So she's, so Miss Sally also needs to come down and get a test or get vaccinated. And listening to that, and you understand that we have now given her a new opportunity of access. She now has an email address where she can get her test results. So all kinds of things programmatically should start going through your mind on how to help this situation from just listening to one person. So you got to listen and you got to be sensitive to what people are telling you.
I love that. And I had to learn early on that when you're working with communities, you start with them in the center of gravity, not your own experience. Because when you start with them in the center of gravity, you begin to understand what they are confronted with, not what you assume. And I'm going to quickly to you, Ron, about the whole critical workers piece. Then I'm going to pivot to participant questions. I have two here. I come from a family of what's, quote, critical workers, i.e. janitors and bus drivers and you name it in Detroit. And my family, they wake up every morning with the thing in mind. I got to get to work on time. I got to get this done to get back home. Very rarely do they think about their health. How can we design, or have you seen designs where workers are educating workers about this moment in their health?
Oh, most definitely. In the union structure, we have a network within ourselves. So one of the things that we've done at the Federation is we've communicated, through our comms department, obviously, positive messaging around the vaccine. Because in our office is actually in a neighborhood called Pico Union in Los Angeles. And it's one of the hardest hit. They even closed the local grocery store there because of multiple infection for the workers in there. So we have an infrastructure within labor, right? Because again, we're connected to community, we're connected to clergy, right? We're connected to workers, nonprofits. So it's all encompassing. And we send a message out through to our 300 affiliates. We have 800,000 union members in Los Angeles. And then, hundreds of thousands more that aren't, but they listen to us. They have confidence in us. We're an institution of pride and loyalty, but trust also. So the labor movement is similar to a community center. And, it's a social club, at times. And because of our relationship with clergy and churches, we have created a collaborative of trust, but we're sending out a positive, statement. So our communities, right, those that are hardest hit will trust us. And when they get the opportunity to have a vaccine, they definitely will.
Susan, I'm going to bring you back to the conversation. This is a question from Lauren in DC. How do we better replicate community-based efforts to gain greater equity in distribution and overcome barriers to access such as transportation, language, location, technology required for registration? Susan, you want to take that one?
Yes, I'd love to. I was hoping to get this one, and thanks to Lauren in DC. So of course, forums such as this are a great way to highlight these local innovations so that we can learn from one another and hopefully scale them. While each community's approach follows some general themes and strategies, I want to emphasize that the on-the-ground interventions within a community, those interventions, those tactics themselves, are likely more specific to the community. We can learn from them. Some of those are not as scalable as some of the more general strategies. And we want to make sure that we continue to encourage those local interventions. So again, we can leverage best practices that can be replicated, but we want to make sure that we support, and here I go again, and fund those practices that are new or more specific to the community. So there's really an opportunity here for funders to consider how to leverage the expertise of the local community-based organizations who know their communities best. Oftentimes, and I'm sure my fellow panelists know this, grant requirements are written at the funders level, and we oftentimes try to pivot to meet the expectations of that grant funding. It's really time to shift that dynamic. Our community-based organizations know the needs. Let us tell the funders what the needs are and make that pathway to that funding a little easier. And then we will be able to attain the equity goals that we have. So I'd simply say that if we could start to flip the model and ask the CBOs what their communities need and try to fund those, that can do a lot to bolster the work and to fund the work within the communities, but also to create scale so that other communities across our nation can learn from them.
Great, great. So this question is from Wing from Missouri. This for anyone. How can we best ensure vaccine implementation in rural areas that may not have access to healthcare departments or hospitals? Anyone? Oh boy, the rural question is always the hard question here.
Well, Derek, I can probably take a swing at this one. Well, a lot of our efforts around our communities is that we don't want to leave anybody out. And so recently, some of the efforts that we want to get vaccines and push vaccines out, but we might be missing a pocket of individuals that might not have access to transporting themselves to a hospital or a healthcare center. And I think a lot of the concern around there is just that they need to be around a hospital unless if there's any allergies or any precautions they need to take. And I think from our side, there was some sort of just staying near the hospital or at the hospital to do vaccinations was the best idea. And now that we're coming into where we know there are gaps of missing elders in either high-risk populations or those with disabilities, there are some efforts on mobilizing to the communities that are far from the hospitals or any sort of healthcare clinic. So that's part of the effort that we're strategizing now to mobilize and move into those areas. And hopefully we can catch everyone that has been probably overlooked and may not have access. And then also encouraging our citizens to let people know if you have someone that has not been get a vaccine, even though they're eligible, find ways to help that citizen. So help each other kind of concept is what I tried to message out. So those are just some things I wanted to share. Back to you.
Derek, let me add to that, because one of the things that's important is that you've got to know what you don't know. And if you've not come from a rural community and you don't know how rural communities live, and then you try to create something to put on top of them, it may not work. So one of the things that we've done is we've gone and partnered with the Alabama Black mayors. There's 60 Black mayors in Alabama representing many, many rural communities. To ask them to help us to put together the paradigm for how to help them get vaccines into the churches of those smaller communities, even storefront churches. We've also engaged with the Balm and Gilead, who through the HIV/AIDS epidemic has set up a very extensive network in rural communities so that we can use their networks, the same networks that they use to get people tested for HIV and services to those communities. We can put vaccines into those communities. But again, I want to stress what I don't think I can stress enough what both I think Susan and I have said. The resources are critical. We have to stop asking people in these communities particularly the rural communities and the underserved communities, to do these things with nothing. Now, we went out and found money. We went to all these corporations were crying out about Black Lives Matters after George Floyd. And then they sent letters out saying that they were on the side of Black Lives Matter. Then you heard very little from these corporations. It is time for all those corporations to come back and realize that we have a crisis and these communities are dying. And it's not all right anymore to just put a letter out there. We need you to come with your resources and help these communities, help foundations like Susan's, help organizations like Ingrid's, and get the money on the ground into the communities where the communities on the ground doing the foot soldiers work. And that is what has become very, very critical.
As we turn the corner on the conversation, I'm going to ask each one of you for a few minutes of final thoughts. What would you like to share that you didn't get a chance to share about your work in this moment? I'm going to start with the first person I see on my screen here. It's you, Ingrid. You up?
Well, I guess I have a few thoughts rambling in my head. I definitely want to emphasize the importance of paying the partners. That's been brought up a couple times, and that's something we learned really early on in the collaborative. And it was a lesson from a partner that said, this takes a lot of work on our end to do this outreach and assist with this staffing. So that's become a model now of, with our funding, is it's passed through to the partners in order to make this sustainable. And I don't know that we'd still be here 15 years later if that model wasn't in play. And that's what we're looking for now as well, is some more robust funding in order to get these community partners involved in a way that gives them credit and resources to really do this essential work. And then I think I would just share some real practical kind of tactical pieces on how other systems, like a healthcare system like the one I come from, might be able to replicate what we're doing. And I would say that, do an asset-based assessment of your own existing partnerships and relationships. Look within. Do you have employee resource groups or employees with ties and influence in the community that you can follow home and with an invitation and plan together how you could serve a community need? Again, what can you bring to the table? If you have more resources, how can you be an equitable partner? And again, share funding, ask what your partner would need to engage in this effort with you. And then one thing too is simplify your system. So these complex registration requirements we learned with COVID testing, really pose a barrier. And we're going to see similar with vaccinations. So how can you really pare it down to just the essentials of what you need? We actually use paper consent forms and a really simple sign-up process. And we're working through it, we're learning through it. But again, we find that just the more complex you make it, the more barriers you put up. And so, do your outreach in the community's language on channels that resonate, and of course, conduct your clinics in as fully as possible in that target language. So just some really tactical things that I think I wanted to share, with hopes that other health systems and community partnerships can do more of this mobile community-based vaccination and do it soon.
Got it. Susan? You're on mute, Susan. Susan, you unmute, please. Oh, we're about to lose Susan, but she sat back down. I want to come back to Susan. Go ahead, Ms. Fraser Howell. Please unmute.
Let me see if I can get out of mute.
You got it.
One of the things that I want to say to the people that are here, I saw the survey numbers, and if you add those that said that they were going to deal with organizing leaders, and those that said that they wanted partnerships and those numbers that sort of look like people were talking about not just reaching to their own communities, but outreaching to the community at large. It came out to about 60 or more than 60% of the people who answered the poll, the last poll that you put up. So I want to emphasize the importance of that, and that community is not just who you go to school with, who you go to work with, who you ride the bus with in the morning. Community is those with whom you have an intertwined destiny. And that could be a lot of people. And you need to find those people who have that intertwined destiny to help guide the decision and the movement around the process that you're taking to the community to now get them to engage in a vaccine program. That's my final word. Thanks, Derek.
Thank you. Okay, Susan, we got you now?
We do. My whole
All
screen
right.
went blank. I lost all of you. So I wanted to go back a little bit to about how to sustain trusting relationships. I just wanted to touch on a few things. So one is pretty obvious, and it's something that community-based organizations do all the time, but I encourage all local organizations to do this, and that is to really prioritize hiring from within your community and ensuring that your workforce is representative of the community. So as I said, community-based organizations such as health centers, this is a priority for us, but we need to see our banks, insurance companies, et cetera, doing exactly the same thing. And so not only does this workforce, again, as we all know, provide voice and lived experience of our community, it also creates economic empowerment through jobs, and it creates diverse leader roles so our younger generation can see what they can aspire to. I also wanted to offer that for many community-based organizations, a robust community outreach team is essential, and health centers have these. I think we all have them, and not to focus on the word funded, but these roles are unfunded, they're not covered by insurance, and they do require philanthropic and grant support. So just to tell you a sort of a tale of woe, when the pandemic hit in March, honestly, we didn't know if we were going to make payroll. We thought we had about 4 weeks of payroll on hand. And so we were one of those health centers out there. And it pains me to share this, but we had to furlough 30% of our workforce, which meant that we were taking that economic empowerment away from our community members. And that is a decision that will stay with me for the rest of my life. We knew when we were making the decision to furlough staff is that we had to maintain a core of our community health workers and outreach team. We knew they were going to be essential to future efforts. We had no idea what those future efforts were going to be, but we knew that they would be essential. And so we took the financial risk to maintain that workforce for that down the road future work. So we had to find a way. We just took the risk. And, I tell you, if we had decided in that moment, and I think all of us can remember that moment in March, for especially organizations that run pretty low at the break-even line or a little bit under, we had to make these difficult decisions. And if we had to furlough that outreach program entirely, our health center has been around for 50 years. That one decision, we would have eroded 50 years of trust building. So we maintained that core, and that core has been at the heart of everything that we do ever since. They've done contact tracing when the state needed us to participate in contact tracing. They're delivering meals and necessary medical equipment. So these are the people who I love dearly, and they are most connected to our community. And so just making sure that all organizations understand that in the midst of all the decisions we have to make quickly, these outreach teams are absolutely the lifeline to our community members. Thank you.
Thank you. All right, Ron, any parting thoughts?
Yeah, COVID actually peeled back the onion. And a lot of people are saying, you know, God, I wish we'd go back to normality, right? Normal times, what does that look like? Well, normal times to a lot of people look like poverty. Normal times for a lot of people means no health care, homelessness. So I want to part with the audience. I send a message to respect workers. When you hear stories about meatpacking plants of, let's say, 250 workers and 150 of them are infected, or on the agricultural side, when immigrants or even undocumented workers of, let's say, 400 pickers in an almond field, and 150 of them are infected, and those that are infected take that infection home to them, to multi-generational homes, or grocery workers, right, in Los Angeles, 1 out of 6 are infected. That's not normal. And we have an opportunity with the new administration to do a lot of good things for people that, you know, aren't at, like I said earlier, in the middle class. In Los Angeles alone, just my entity, right, the County Federation of Labor, has fed 500,000 people. It's incredible, right, the need of subsistence. So in parting, I just want to say respect workers and sympathize with them, because they need you all. They need all of us. Thank you, Derek, and thank the panelists. This has been great.
Okay, great. Well, Dr. Jill, Jim, using a baseball analogy, you are the cleanup hitter. Time for you to hit the grand slam. What are your final words?
Well, my final words are just making vaccine accessible and working with partners and educating ourselves with all the different racial and ethnicity groups across the U.S. and including our own population with tribal communities, just understanding our relationships. And this is something new, something we didn't expect, but I think that there's always room to improve. And if something isn't working, always try something different. But I think vaccine access to everyone and making sure there's no denials and working with every population is very important. So that would be my parting words. Thank you, Derek.
Thank you to all of the panelists. And the speaker asks, who will speak for those who cannot speak for themselves? And what I heard was 5 amazing panelists who are stepping up at this moment to ensure that communities who are most deserving have the voices, the access, and the opportunity to be serviced. Because in this society, we cannot do for the least of these. Who will be able to prosper? No one. Thank you all for this opportunity. I'm going to wrap up and make sure that participants, if you have any information you want to share with the audience, put it in the chat box so they know how to get in contact with you or anything of that nature. I'm going to thank the CDC for putting this conversation together. I believe that we have now begun to turn the corner on this global pandemic, because for far too long, we've seen the global impact and we didn't have a federal response. Now we have a federal response so that we can have a local opportunity to weather this storm. I have attended far too many virtual funerals as a result. We should not die for something that's so preventive. So let's continue the work. And thank you to the new administration. Thank you to the CDC. I want to thank all the panelists for the opportunities. Thank you and take care.